Please stand by. Good day, everyone. I'd like to welcome you to today's Coag 101 conference call hosted by Diagnostica Stago Incorporated. Before I introduce today's host, I'd like to make sure you'll be able to view our webcast. Again, please go to www.visioncast.com. Once there, please type in your full name, your meeting ID, which is lowercase w 966781, and the meeting password, which is uppercase H, 7, uppercase B, uppercase M, uppercase S, 5. Please click on the Submit button and stand by as the meeting console loads. If you have any difficulty accessing the materials, please press *0 at any time to speak with a webcast technician. You are also encouraged to disengage your screensaver program. Second, all audience lines will be in a listen-only mode during today's program. However, audience members are able to submit questions to our speakers throughout the entire presentation, and we will address as many questions as possible at the conclusion of the speaking portion of the call. To submit your web question during the presentation, please locate the question box labeled Ask a Question found in the lower right-hand portion of your screen. Type in your question and then click Ask to get your message to our Q&A panel. Once we receive your initial question, you are welcome to send another question simply by entering in your next question and clicking on the Edit button. To see a full screen showing of the slides, simply press Control-H on your keyboard. Please press Control-H again to minimize your screen to submit an internet question. One last note, today's program is being recorded. At this time, I'd like to introduce your host for today's program, Dr. Laura Worfolk. Please go ahead.
All right, this is Laura. Thank you, everyone, for joining us. This is our last web-based teleconference of the year. Title is Coag 101, the PT and the INR, and this topic was, asked for by everybody in previous sessions, so that's why we're doing it today. We will be doing 4 more next year, so just keep on the lookout on our website for when those will be posted. Now, for those of you who are not viewing through the website, I will refer to the slide number, which is at the lower right-hand portion of the slide. For those of you viewing on the website, you don't need to advance the slides. I'll be controlling that. Now, moving on to slide number 2, as far as PACE information is concerned, if you would like to receive PACE credit, we are a PACE provider for every state, including Florida. We just had that renewed. We do need you to perform a program evaluation. If you're viewing on the website, please stay on the line. At the end of the lecture, we'll do a very quick online evaluation. If you're not viewing on the website, please email the evaluation form back to us. We sent those out on Friday, I believe. If you did not get the evaluation forms, please contact Naomi McDonald at the email address shown on this slide. We also, in order to process the certificates, we need everybody's name. So fill out the participant list form with your name and also email that back to us. And probably mid-January we'll get the certificates back to you. Now, if you are in Florida, please include your license number because I will be posting the credit on the CE broker site for Florida. So moving on now to slide number 3, the objective for today's lecture. At the end of this session, I hope that you should be able to, or my goal is that you should be able to describe the major pathways leading to thrombin generation. Keep in mind this is an introductory lecture, so it is not my intent that everybody will be able to regurgitate the whole coagulation cascade. I'm hoping you just get a general idea of how we make thrombin and eventually clot. Also, you should be able to recall the mechanism of the action for warfarin therapy, be able to discuss the principle of the prothrombin time test and the purpose of the INR. And last, and what I believe to be the most important objective for today, is to list the factors that will affect accurate and precise INR reporting. Because the bottom line, we all work in the laboratory, and our goal during the workday, it's our responsibility to make sure that we are reporting out the correct results. So moving on now to slide number 4, hemostasis is a process by which your body maintains blood fluidity in the vasculature and stops bleeding. And it involves many different components. They are the fibrin-forming systems, or the Coag system, which I'll be talking about today, the fibrin-lysing systems, or the fibrinolytic process, and I won't be covering that today. And then there are many different cells that are involved. such as the platelet, the monocyte, and the endothelial cells. On slide number 5, some of the highlights of coagulation are summarized. And coagulation is a series of fairly complex reactions leading to thrombin generation and eventual fibrin clot formation. Now, once we get to that stable, insoluble fibrin clot that's formed, that is when the bleeding will stop. And in order to get to that point, we need to generate thrombin. Thrombin is critical for the process, and therefore there are many different processes which have been developed by nature to tightly regulate not only the generation of thrombin, but also the activity of thrombin. Now, a recurring theme in coagulation is for the requirement of factor and cofactor complex assembly on the damaged cellular surface or at the site of injury. And factors and cofactors are simply proteins which function together. They need each other. So I think of this as nature's perfect buddy system. Because what a factor will do is once it is activated, it will express a specific enzymatic activity. And in order for that activated factor to express its maximal enzymatic activity, it requires the help of a specific activated cofactor. The cofactor by itself does not have any enzymatic activity, but it enhances the activity of its factor. Now, the cofactors will function to assemble the factors on the damaged cellular surface and also to localize and amplify reaction. So this is another way of controlling the process because we don't need systemic coagulation going on. We just want the reaction to occur where the injury occurred. Now, another commonality in coagulation, and as well as in fibrinolysis, is that all of these proteins circulate in plasma in an inactive form. They require activation at that site of injury to express their normal enzymatic activity or their normal cofactor activity. And last, the product of one reaction becomes the activator for the next reaction. And this has led to the concept of describing coagulation as a cascade-like series of events. In actuality, they're probably happening so quickly and almost simultaneously, but for the purposes of describing the whole system, it's usually presented as a cascade. Now, moving on to slide number 6, the cellular contribution by the endothelium is summarized. Now, the endothelial, well, I should backtrack a little bit. All of our blood vessels are lined with an endothelial cell lining. And the endothelium maintains blood fluidity by producing specific inhibitors of coagulation as well as inhibitors of platelet aggregation. For example, the endothelial cell secretes a glycosaminoglycan, which is called heparan sulfate. And when a circulating anticoagulant called antithrombin binds to heparan sulfate, which is secreted by the endothelial cell, antithrombin becomes a much more potent inhibitor of coagulation. In addition, the endothelial cell also secretes another protein called thrombomodulin. And once thrombomodulin binds to thrombin on that endothelial cell surface, it no longer is procoagulant. It cannot cleave fibrinogen to fibrin. It's its major substrate. In addition, there are inhibitors of platelet aggregation, such as nitric oxide, prostacyclines, and ADPase. The endothelium also modulates vascular tone and permeability. In fact, when you do have a break in that endothelial cell surface, there'll be a constriction of the vessel, and then that is again to prevent severe blood loss. And last, the endothelium provides a barrier between flowing blood and reactive subendothelial components. And the one that I'll talk about today is tissue factor. When flowing blood is exposed to the subendothelial protein tissue factor, that will initiate the coagulation cascade. Now, the cellular contribution made by the platelet is summarized on slide number 7. Now, the only function in life for the platelet is to participate in coagulation. So they live and die clotting. Platelets will circulate in the blood, and they're on the lookout for a site of injury. And when they see a site of injury, and obviously they don't see it, but I'm just using that terminology because it's easy for me to visualize it, they will adhere to that area of injury. And that adhesion is mediated by a platelet receptor called glycoprotein 1b binding to von Willebrand factor. When they adhere to that site of injury, they will recruit other platelets to that area, and they become activated and they aggregate. And those reactions, or the aggregation and platelet recruitment, is mediated by the platelet receptor glycoprotein 2b3a binding to fibrinogen as well as von Willebrand factor. Von Willebrand factor is a large plasma glycoprotein which is very important in coagulation. As you can see, if you don't make enough von Willebrand factor, or if you have a mutation in your von Willebrand factor gene and make a broken molecule, your platelets cannot adhere to the site of injury, nor can they aggregate as well as they should, and these patients will have bleeding problems depending on the level of their deficiency. Also, von Willebrand factor will bind one of the important cofactors in coagulation, and that is factor VIII. And by doing that, it protects factor VIII from proteolytic degradation in the plasma. So von Willebrand factor is very important in coagulation. Getting back to the platelets, when platelets become activated, they will secrete the contents of their granules, and I'll only just mention one as an example. They will secrete from their granules one of the activated cofactors, which is 5A, and 5A is needed, is the cofactor for factor 10A, and the 10A5A complex will activate prothrombin to thrombin. And last, the platelets provide the surface area for eventual fibrin formation. So they will adhere to the site of injury, they will aggregate, they'll start plugging up that hole, they will become activated, they will undergo a major change in their membrane surface, and they will provide also the surface area for many of the reactions leading to thrombin formation. So moving on to the next slide, which unfortunately doesn't have a number, it's the slide with the white background. I obtained this slide from Dr. Charles Francis from the University of Rochester School of Medicine and Dentistry, and this is a nice illustration of the very complex coagulation cascade, and there's arrows going all over the place. Again, the critical component, or the critical player, is thrombin. When thrombin is generated, it will cleave the large plasma protein fibrinogen to a fibrin monomer, and that fibrin monomer will eventually become stabilized, and the resulting cross-link fibrin clot is generated, and that's where the bleeding will stop. Well, how do we get to the formation of thrombin? I'm not going to use this slide to actually describe how we get to thrombin because I think it's a little bit too complex for an introductory lecture. I just wanted to put it up here to illustrate how complex the reactions really are, and also this slide represents the work of many different scientists over many, many different years and a lot of hours spent in the laboratory working these pathways out. So moving on to slide number 9, this is my version of an abbreviated cascade. Again, we want to know, how do we get to thrombin, which is going to cleave the fibrinogen and form the fibrin clot? Well, when there is an injury, there's a break in the endothelial cell lining, and that can be a mechanical injury. You cut yourself with a knife, or it could be biochemical. The subendothelial protein called tissue factor is exposed to flowing blood. And I've already lied once in this presentation. I said all of the factors and cofactors circulate in plasma in an inactive form. Well, the one exception to that rule is for factor 7A. We all have a tiny amount of circulating 7A, about 1% of the total 7. So 7A will bind to tissue factor, and the tissue factor 7A complex will activate factors 9 and factors 10. The tissue factor 7A pathway of 10 activation is referred to as the extrinsic pathway because tissue factor is extrinsic to the flowing blood. Once there is a little bit of 10 activated with its cofactor factor 5, we'll activate a little bit of prothrombin to thrombin. The tissue factor 7A complex will also activate 9 to 9A, and 9A with its cofactor factor 8 will also activate factor 10. This is referred to as the intrinsic pathway of 10 activation. So there's actually two pathways of 10 activation. However, they are not redundant. Moving on to slide number 10, this illustrates some of the feedback activation and amplification steps that occur. Once a little bit of thrombin is formed, it will activate the critical cofactors 5 and 8. And once we have activated 8A, that's going to better help 9A activate more 10 to 10A. Same thing for 5A. It's a much more efficient cofactor for 10A. So what will happen is we get a burst of 10A activation and a burst of thrombin generation, and of course more fibrinogen being cleaved to the fibrin clot. Now, as I mentioned, the two pathways of 10 activation are not redundant. There is the tissue factor 7A pathway is primarily responsible for the initiation of the whole pathway, because there is another inhibitor which is secreted also by the endothelial cells called tissue factor pathway inhibitor. And tissue factor pathway inhibitor will shut down the tissue factor 7A pathway of 10 activation. So it is primarily the 9A, 8A pathway of 10 activation which takes over and is responsible for the majority of thrombin that's formed, eventual thrombin. And that is why patients that are deficient in either 9 or 8 will have severe bleeding problems. And those patients are referred to as hemophiliacs. Now, on slide number 11, this just lists some of the ways that thrombin is regulated. And there's two main ways to regulate thrombin. There are direct ways to actually inhibit thrombin activity, as well as to inhibit the formation of thrombin. As far as inhibiting thrombin formation, one mechanism is through the circulating inhibitor called antithrombin. And I've already briefly mentioned how antithrombin works. It's a circulating inhibitor. We all have it in our blood. And it will bind to heparan sulfate, which is expressed by our endothelial cells, or it will actually bind to the drug heparin if you were to be given the drug heparin. And once antithrombin binds to heparan sulfate or heparin, it will undergo a dramatic change in shape, and now it is a much more potent inhibitor of thrombin, as well as some of the other enzymes involved in thrombin generation. The other endothelial cell protein, thrombomodulin, once thrombin binds to thrombomodulin, it is no longer procoagulant. So it can no longer cleave fibrinogen to the fibrin clot. However, the thrombin bound to thrombomodulin can activate protein C. And the protein C and the protein S pathway is one way of inhibiting thrombin formation, because what will happen is thrombin bound to thrombomodulin will activate the protein C, and activated protein C with its cofactor, protein S, will inhibit the important cofactors 5A and 8A. And we need those activated cofactors for maximal 10 and prothrombin activation. So if you shut down the cofactors, we're going to dramatically shut down the overall rate of thrombin formation. Another way of inhibiting thrombin formation, again, is through the action of antithrombin, because antithrombin, once it binds to heparin or heparan sulfate, not only knocks out thrombin directly, but as I've mentioned, 10A and some of the other enzymes upstream of thrombin generation. And last, I've already mentioned tissue factor pathway inhibitor. This is also secreted by the endothelial cell. And tissue factor pathway inhibitor will form a complex with the tissue factor 7A, 10A complex and shut down this whole pathway. So these are just a few of the ways that thrombin activity is regulated, and they're all very important. Now I'd like to move on to slide number 12 to move on to oral anticoagulant therapy, otherwise known as warfarin, which is the generic name. Brand name, I believe, is Coumadin. There may be other brand names. I'm just not aware of what the other brand names are. And then in the general population, it's lovingly referred to as rat poison or blood thinners. Now, this is actually my favorite part of the lecture because I'm a little bit of a history buff. The discovery of oral anticoagulants, I think, is a really interesting story. Turns out in the 1920s, cattle in the United States and Canada were dying of a bleeding problem. And what happened, or what the association that was discovered by Schofield, they were able to link the bleeding disease to the use of spoiled sweet clover, which is breeding. They also showed that they could control the bleeding by taking away the spoiled sweet clover and also transfusing the cows. And I can't imagine how easy that must have been, but they did it and were able to demonstrate it was the sweet clover that was causing the bleeding. And the clotting test that they had available at the time suggested it was related to some type of prothrombin defect. Well, in 1932, a Wisconsin farmer named Ed Carlson lost 2 heifers and 3 cows to this bleeding disease. Also, his prize-winning bull was bleeding through the nose, so he was fed up. He didn't trust his local vet, so he took one of the heifers and he loaded it on the back of his Ford pickup truck, and I'm not making up these details. So he loaded in the back of his truck the dead cow and also a milk can of unclotted blood and also the spoiled sweet clover. And he drove 190 miles in a blizzard to where did he go? Oh, yeah, to the Madison State Veterinary Scientist headquarters. And it was a Saturday, so everything was locked up except one laboratory, and that's where Carl Link was working. And it just so happened that Link had just started working on the sweet clover problem about a month before he was confronted by this really angry farmer, because apparently he just brought the dead cow into the lab. I don't know what he was expecting, but he demanded that something be done. So it took 7 years, but eventually Link identified the causative agent as dicumarol, and what it turned out was that when you go by a field that has just been hayed or cut, I don't know what the correct farm terminology is, but the smell of freshly cut hay is due to coumarin. There's natural coumarin in sweet clover. And when it becomes spoiled, if it becomes damp, the bacterial action will convert the coumarin to the anticoagulant dicumarol. So this was a major discovery. It took many years, obviously, and eventually they were able to synthesize the agent. And they first used it as a rat poison, and obviously it was very effective. And then eventually they synthesized the drug so that it was safe enough to use in humans. And in the 1950s, President Eisenhower was one of the first patients that was treated with this drug after he had one of his heart attacks. So just thought that was an interesting story. Oh, and more trivia, warfarin is named after the Wisconsin Alumni Research Foundation, which funded the research. So how does this drug work? On slide 14. Well, it inhibits the formation of fully functional vitamin K-dependent proteins. And the vitamin K-dependent procoagulant proteins are prothrombin, which is factor 2, factor 7, 9, and 10. Also, the anticoagulant proteins C and S are also vitamin K dependent. So why is vitamin K so important in coagulation? Well, it turns out it's a cofactor in a necessary carboxylation step. And carboxylation of these proteins is required so that they can express their normal biologic activity. And more coag trivia for you. Foods that are very rich in vitamin K are the green leafy vegetables, spinach and broccoli and I guess maybe collards, I'm not really sure, but anything green, it's got vitamin K in it. Now on slide number 15, the biochemistry of the vitamin K cycle is illustrated. And on the upper left-hand portion of this slide is illustrated a prothrombin precursor, which has glutamic acid residues. And each protein will have multiple glutamic acid residues. And in the final processing step, and this is occurring in the liver, it undergoes a carboxylation reaction where the reduced form of vitamin K serves as the cofactor for this end. The end result is a prothrombin molecule which has multiple gamma-carboxyglutamic acid residues. And those residues are required so that the protein can bind to calcium, and that serves as a bridge for binding to the phospholipid membrane surface. In the reaction, vitamin K is oxidized. And on slide number 16, in the normal situation, the oxidized form of vitamin K is regenerated to the reduced form of vitamin K. Again, this is happening in the liver. And warfarin is believed to interfere with this regeneration step. So if a patient is on warfarin therapy, they will have a decreased amount of that reduced vitamin K and therefore be able to perform this carboxylation reaction. And as shown on slide number 17, the liver will still make these proteins and secrete them, but they will be non-functional coagulation factors. So a patient on warfarin therapy, warfarin will interfere with the vitamin K cycle in that liver. Now obviously, if all of a sudden you go on warfarin therapy and you start eating a lot of, all of a sudden you're on a health food kick and start eating a lot of spinach or collards, green leafy vegetables, you're going to antagonize warfarin therapy. Now the half-life of the vitamin K-dependent proteins are shown on slide number 18. And unfortunately, one of the drawbacks to warfarin therapy is that it does take several days, 4 to 5 days, for the full anticoagulant effect to kick in. And that is because all the vitamin K-dependent factors have different half-lives. For example, factor 7 has a half-life of 4 to 6 hours, whereas prothrombin has a half-life of 60 hours. So when a patient is first on therapy, the prolongation of their PT time is the result of the reduction in their 7 levels. Now, because it takes several days for the full effect of the drug to kick in, patients are often going to be on heparin therapy at the same time. And moving on to slide number 19, warfarin has proven to be a very effective anticoagulant, and it's been with us for over 50 years now. However, the drug is far from perfect, and it has many limitations. As I have already mentioned, it has a very slow on and offset of action due to the differences in the half-life of all the different vitamin K-dependent proteins. There's also, unfortunately, a lot of variability, not only between patients in the way they respond to the drug, but also within patient variability. And that is because the drug is susceptible to many food and other drug interactions. I heard a very interesting story at one of the Temple Coag meetings a few years ago. The speaker was relating an incident where they had a patient in the hospital, put them on warfarin therapy, and days were going by and their PT and INR was just not getting into the therapeutic range. And it turned out that the patient obviously did not like the hospital food, no surprise there, and was having their family bring in food, and they really liked guacamole. So he was eating a lot of guacamole, which is high in vitamin K, so that was negating the effects of the warfarin drug. So not a time to develop a guacamole craving. There are also genetic factors that will affect warfarin therapy, and I'll just briefly mention one. There is mutations have been identified in the enzyme that is responsible for the metabolism of warfarin. And if a patient has this specific mutation, they will metabolize the drug at a much slower rate than somebody who does not have the mutation, so therefore they're going to need less of the drug. And last, unfortunately, warfarin has a very narrow therapeutic index. If you give too little of the drug, the patient's at risk for extension of their initial or their original clot. And if you give too much of the drug, they are susceptible to bleeding. And this is especially a problem in the older patient population. Because of all these limitations, laboratory monitoring of warfarin therapy, as you all know, is absolutely required. Now, Before I get on to the PT and the INR, just a few words on warfarin therapy monitoring. When a patient is first given the drug, they are tested every day until their INR is stable, and then every 4 weeks. But this is going to be dependent on the patient. Some patients, if they have other medical problems, they're on other medications, or maybe they're taking herbal medications, that may interfere with their warfarin, so they may require more testing. I know personally, if I had to take the drug, I'd probably want to be tested every 2 weeks. 6 weeks seems a little bit long to me, but that's the current recommendation. As far as the therapeutic ranges, the goal for most indications is an INR of 2 to 3, and in a small number of indications, a slightly higher INR of 2.5 to 3.5. Slide 21, I now would like to focus for the rest of the lecture on the PT and the INR and the specific laboratory issues that we have to be aware of. Slide 22 illustrates the principle of the prothrombin time test. It's a very simple test. Plasma is mixed with the reagent, which contains thromboplastin. All thromboplastin is a source of tissue factor, calcium, and buffers. The reagent can be made from human brain, which is very rich in tissue factor, rabbit brain, which is what the Stago reagents are made from, placental. I'm not sure if there's any commercial placental reagents still available, and also there's recombinant reagents. But once plasma is exposed to that source of tissue factor, clotting is initiated, and the endpoint is time to clot formation. Why do we use the prothrombin time test to monitor warfarin therapy? Well, 3 of the vitamin K-dependent procoagulant factors will be picked up by the prothrombin test, and they are factors 2, 7, and 10. The prothrombin time test is probably the #1 test that is performed in the routine Coag lab, and that is because it is used to monitor oral anticoagulant therapy. And moving on to slide 23, historically the prothrombin time test has been around since the 1930s. It's a reliable clinical test. However, the problem with respect to monitoring warfarin therapy is that different reagents varied markedly in their responsiveness to warfarin. So what this means is that results in seconds were not comparable between laboratories, reagents, or instrumentation. So this problem of non-standardization was addressed by the incorporation of the INR system. I think it was first described in 1984, and the INR system is the International Normalized Ratio. Moving on to slide 24, the INR is a mathematical correction of the PT ratio. And the PT ratio is your patient PT result divided by the laboratory mean normal PT result. And this whole system relies upon the use of international reference thromboplastins, which have a known responsiveness to the reduction, the warfarin-induced reduction of the vitamin K-dependent procoagulant factors. Therefore, the INR is the PT ratio one would have obtained if you were using the reference thromboplastin in your laboratory. And the INR system then allows for comparison of results between laboratories, and it standardizes the reporting of the prothrombin time. On slide 25, the calculation of the INR is shown. It is equal to the PT ratio raised to the power of the ISI. Well, what is the ISI? That stands for the International Sensitivity Index, and it is a measure of the responsiveness of a given reagent compared to an international reference preparation. The lower your ISI on your reagent, the more responsive that reagent is going to be. Now, the ISI is assigned by the reagent manufacturer by calibration against the international reference preparation. And if anybody would like more specific detail on how that is actually done, you can ask that question at the end of the lecture. Now, with a low ISI reagent, if you were going to test a plasma sample from a patient in warfarin therapy, say, for example, you may get a PT clotting time of 60 seconds. If you then were to go and test that same sample with a reagent that has high ISI value, you may only get a clotting time of 20 seconds. So the lower the ISI, the more responsive that reagent is to the reduction in those vitamin K dependent factors. On slide 26, these next couple of slides I obtained from a really interesting, good presentation that's available on the website, the American Heart Association. And this is illustrating the effect, the thromboplastin effect on the PT ratio and the INR. And in this example, if you take blood from a single patient, test it with 5 different thromboplastin reagents, you can see the patient's PT will vary from a low of 16 seconds to a high of 38. Mean normal really doesn't change. It's about the same between all reagents. If we calculate the PT ratio, we get a low of 1.3 and a high of 2.6. So obviously you could not use the PT ratio or the patient's PT time to monitor and adjust therapy, especially if they were going from a small hospital to large hospital or doctor's office to university medical center. It would be very difficult. On slide 27, the calculation of the INR is shown. So again, now what we've done is we've calculated the INR using the ISI. And again, this is theory. It doesn't always work this way. But no matter what reagent was used, the INR was 2.6. Again, this is just a theoretical exercise on how the INR standardizes PT reporting. And this is why the INR is now used to monitor and adjust oral anticoagulant therapy. In real life, it doesn't always work as perfectly as this example. Slide 28 is some real data that I obtained from one of our customers. They were switching from the Neoplastin D on a CA6000 and to Neoplastin CI Plus on the STA. And this is an INR correlation plot. Again, this is real data. So even though the PT times were dramatically different between the two systems, the INRs had a good correlation. Slide 29. Now the INR system was a vast improvement over just reporting in PT or PT ratio. However, it is not perfect. And there are some problems that we do have to be aware of with the INR system, ranging from your reagent responsiveness to onset of therapy, use of high ISI and its effect on your precision, and all these others that I have listed on slide 29. I will be going through all of these in more detail because this is really where the laboratory comes into play. On slide 30, the effect of the ISI on your therapeutic range is discussed. Now, as your reagent responsiveness decreases, which means your ISI is increasing, this means that the prolongation of your patient PT relative to the mean becomes smaller. So from a practical point of view, this means that it's more difficult to adjust dosage. I think this is best illustrated on slide number 31. This was a study where they were evaluating 2 different reagents with vastly different ISIs, an ISI of 1 and an ISI of 2.4. I don't believe you can even buy a reagent like that in the U.S. anymore. Hopefully not, but back then maybe you still could. And what they did in this study is they calculated the therapeutic range for the PT and the PT ratio that corresponded to an INR of 2.5 to 3.5. And with the low ISI reagent, the PT time in seconds, the therapeutic range was 30 to 42 seconds. In contrast, the second reagent had a therapeutic range of 17.6 to 20.2 seconds. So from a practical point of view, it's much easier to get a patient within that therapeutic range when you have a 12-second target versus a 3-second target. I mean, it's just probably not possible. What would happen is the patient would be in, and they'd be redrawn again, they'd be out, so they'd be bouncing back and forth. So one of the advantages to a low ISI reagent is a wider therapeutic range. Current CAP recommendations is to use a reagent with an ISI less than 1.7. On slide 32, some of the issues associated with the onset of therapy are listed. Number one, patients are going to be on heparin therapy, I think 99.9% of the time. Want to make sure your reagent is heparin insensitive, and you can find this out in your package insert. The Stago reagents are manufactured with polybrine, which is a heparin inhibitor, and that will inhibit unfractionated heparin up to 1 units per ml. The second issue associated with the onset of therapy has to do with the fact that, again, the different clearance rate for the vitamin K dependent factors. Again, it varies from several hours for factor 7 to days for prothrombin. And when that ISI is assigned by the reagent manufacturer, we are using samples from patients that are on stable therapy 4 to 6 weeks. And therefore, they are already at their maximal effect of warfarin. So there will be a little bit of discrepancy then during the onset, but it's still better, at least the INR is still better than using the uncorrected PT ratio. On slide 33, this is a mathematical explanation here on how a high ISI reagent can theoretically affect the precision of your INR. Well, we all know the ISI is an exponent. And if we were to calculate the imprecision of the INR, that would be equal to the CV of your INR is equal to the CV of your PT ratio raised to the power of the ISI. So if you are using a reagent that has an ISI of 2, you're just compounding the imprecision of your INR. The caveat, though, is that low ISI reagents may cause a higher CV for the PT value. So you need to select a reagent with an ISI where the product of the CV of your PT ratio raised to the power of the ISI is the lowest. Took me a couple of times to read through this and it. Again, this is all in theory. Looking at the CAP survey results for INR, I would expect, based on this theoretical mathematical explanation, that if you were using an ISI of 1, for example, the recombinant reagents, that laboratory to laboratory variation CVs would be a lot smaller than the higher ISI reagents, and that really has not turned out to be the case. Slide 34, I do have to mention this. How reliable is the ISI value that the manufacturer assigns? Well, unfortunately, the international reference preparations, which all the manufacturers standardize against, the ISI of those preparations are determined using tilt tube technology. Tilt tube, I shouldn't even call it technology, tilt tube method. All the manufacturers are using their specific automated analyzers. So what that means is that is going to introduce some variation into the ISI calculation. Also, the international reference preparations are in short supply. So what the manufacturers will do, and this applies to all manufacturers, is that they will make a lot of thromboplastin reagent and designate that as their in-house standard. And then they will calibrate that directly against the international reference preparation. And then that in-house standard is used for all subsequent lots of thromboplastin reagent. So the ISI on the reagent that you get in your laboratory is actually 2 calibration steps, I guess, away from the international reference preparation. And we're not doing tilt tubes. There also have been reports of instrument variability. I would say that if you have 2 analyzers, say you have 2 STARs or 2 compacts in your laboratory, you do an INR correlation, and they're more than, if you see a bias or more than 10% variation, it's time to call in the hotline and get your instrument checked out. Unless, and this does not apply to the Stago reagents and instrument, some manufacturers of reagents will only provide a generic ISI. For example, they'll only provide a photooptical ISI, and a mechanical ISI, and this really just isn't going to cut it because instruments are different. So the solution then is to use an instrument and reagent-specific ISI, which is what you're doing if you are using the Stago reagents on the Stago analyzers. Slide 35 just summarizes some of the other issues. The determination of your laboratory mean normal denominator in that PT ratio is critical. You cannot use control plasmas because they differ markedly from your laboratory geometric mean normal. Also, as far as pre-analytic variables go, you want to make sure you're using 3.2% citrate tube, which is the current NCCLS recommendation. The reason for this is that the 3.8% citrate tubes, it was found that specifically on samples from patients on warfarin therapy, that the clotting time was a lot longer in 3.8% citrate versus 3.2. So of course your INR is going to be higher than what you would see with the 3.2. So to eliminate this source of variation, the recommendation is 3.2%. And last, you want to know what is the lupus sensitivity of your reagent. And we usually don't think of lupus sensitivity for our PT reagents. We think of PTT reagents being lupus sensitive. But there have been some reports, specifically with the recombinant reagents, that they are sensitive to lupus anticoagulants. So you want to know what your sensitivity is. The Stago reagents, it's got a ton of phospholipid in them, and every study I've seen, the Stago reagents are not sensitive to the lupus anticoagulant. Why this is important is because patients that have a lupus anticoagulant may have had a thrombotic episode, and they may be on warfarin therapy, and if you're trying to monitor warfarin therapy and they have a lupus anticoagulant, and your lab is using a reagent that is sensitive to the lupus anticoagulant, it will be very difficult to monitor that therapy because the prolongation of your PT is being the contribution of the lupus anticoagulant to your PT prolongation. And if I've just confused everybody, you can ask me a question at the end of the lecture. Slide 36 discusses the effect of thrombin inhibitors on the PT and the INR. Now, the three FDA-cleared thrombin inhibitors are argatroban, lepirudin, and the brand name for lepirudin is Worfolk. And these two drugs into patients with heparin-induced cytopenia that also have thrombosis. These patients have mounted an immune response to heparin, so they can no longer get heparin, so they're given these direct thrombin inhibitors. Angiomax is another direct thrombin inhibitor, and it is given to patients that have unstable angina undergoing a specific coronary procedure. Now, these three drugs not only inhibit thrombin in vivo, but they also inhibit thrombin in the test tube. So they will interfere with all thrombin-dependent clotting tests. And with the PT, they will prolong the test result, and that will increase the INR. So it will make it difficult to transition these patients to warfarin therapy. Gosselin and co-workers recently published a study looking at the effect of these three drugs on the PT. I believe they evaluated 12 to 14 different PT reagents. They did titration experiments, and they found that the effect was dependent on the specific thrombin inhibitor. For example, argatroban had the most effect, and lepirudin had the least effect on the PT. It's also dependent on the drug concentration, which makes sense, as well as the specific PT reagent. For example, reagents that had a lower ISI were less affected than reagents that had a higher ISI. This is a good reference to look at, and they did look at the Stago reagents. On slide 37, actually the next three slides, I've listed all the drug interactions with warfarin. I'm just providing these slides as reference. I got these out of the recent CHEST guidelines on anticoagulant therapy. And on slide 37, the drugs that have been shown to potentiate the warfarin effect are listed, and they're divided based on the level of evidence, with studies rated as a 1, being the best study design and maybe number of patients, and then they're ranked with down to level of evidence of 4. Since I don't know what half of these drugs do or can even pronounce them, I'm just, again, providing this as reference. Slide 38 are those drugs that have been shown to inhibit the action of warfarin. And on slide number 39, these are the drugs that have been shown to have no effect on warfarin. So again, it's just a good reference to keep in your laboratory, especially if you get a question about an unexpectedly prolonged or maybe a patient's resistant to warfarin. Could be that they're on another drug that is interfering with the effects of warfarin. Now, what is the future of oral anticoagulant therapy? I'm on slide number 40. Well, probably a lot of you have heard of the new drug called Xanta. The chemical name actually is malagatran. It's an oral replacement drug for warfarin therapy. Patients ingest malagatran and actually undergoes a chemical change to xymalagatran, which is the active compound. And this is being studied as a possible replacement for warfarin therapy. And one of the proposed advantages to this drug is that no anticoagulant laboratory monitoring is required because it has there have been no reported food interactions. So I guess you can go ahead and eat all the guacamole you want. Very little other drug interactions and patient-to-patient variability. Unfortunately, though, the drug came up to the FDA this fall, I believe in September, and the FDA turned it down because in approximately 6% of patients, there was an increase in one of the liver enzymes, in the ALT. So that suggested a slight liver toxicity. Also, I recently heard at the ASH meeting that the drug was also associated with some cardiac problems. The drug is being used and marketed in 15 other countries. So my gut feeling is that this pharmaceutical company, and I can't remember which one it is probably going to pursue this as far as getting FDA clearance. They've done a lot of work on this drug and spent buku dollars on all the studies. So we may see it in the future, and obviously that will have an impact on the coagulation laboratory. Though I think it will probably be so expensive that I don't think warfarin will ever go away. Now, so in summary, effective anticoagulant therapy requires laboratory monitoring, and the INR can be affected by many different factors related to the patient, what other drugs the patient's on, and then there are pre-analytic and analytic considerations that we need to be aware of in the laboratory. At this time, before I open up the line to questions, I would like to just briefly go through that online evaluation. I know some of you have to get back to work. So in the first slide, were the objectives achieved? So just select one. I don't know who's selecting what, so you can just go ahead and select that. And I'll just wait a few seconds for everybody to select their answer. Okay. On the next online evaluation, was the format of this course conducive to learning? This really applies to the web-based learning. Did you like getting a lecture on the website? So from 1 would be poor and 5 would be excellent. Okay, next question. Were the slides useful and clear? So again, 1 poor, 2 below average, 3 average, 4 good, 5 excellent. Next question, what was your prior expertise on this topic? So if this was your first introduction to Coag, I would rate that as a 1. And then of 5, you can recite the Coag cascade verbatim. Okay. Moving on to the next. and what topic would you like to see next? Heparin monitoring, lupus anticoagulants, thrombophilia testing, and QC and QAP and Coag. And it looks like we're going to be, QC is winning out, 37%, 35%. Second place would be lupus anticoagulants. Okay, so now I would like to, you can go ahead, ask questions through the phone or through the internet. If you need to leave the lecture now, you can just send me a question to Naomi and she will forward it to me. Thank you for listening, and we can open up the lines. Are there any questions?
Thank you. Today's question and answer session will be conducted via the internet and phone lines. To ask your question via the internet, please locate the question box labeled Ask a Question found in the lower right-hand side of your screen. Type in your question and then click Ask to get your message to our Q&A panel. Once we receive your initial question, you are welcome to send another question simply by entering in your next question and clicking on the Edit button. To ask a question via telephone, simply press the star or asterisk key followed by the number 1 on your telephone keypad. If you are using a speakerphone, please make sure your mute function is turned off to allow your signal to reach our equipment. We'll take as many questions as time permits, and we'll proceed in the order that you signal us. Again, that is star 1, and we'll pause for a moment to give you a chance to signal. And our first question will come from Jean with St. Luke's Hospital.
I'd like to know if there, what would cause a falsely decreased PT?
A falsely decreased PT? Oh, you mean from a patient on warfarin therapy?
Yes.
So you're expecting that the PT should be prolonged because they've been on the therapy?
Yes, and you get a falsely decreased PT, and then the next time, and then when you repeat it, it's elevated like what they've been running.
Mm-hmm. Well, it could be due to some pre-analyticals. Was your sample partially activated? You know, did you have any microclots that might shorten your PT? Was it hemolyzed? If it's underfilled, it's going to be prolonged, so you could rule that out. Also, I would say if the very next time, like if they're drawing within a few hours and they're as expected, I would probably rule out a drug interaction.
No, I mean with the same specimen. Like the first time you run it, it's like an 11.8, and then the doctor questions the result, and you run it like the next day within the 24 hours, and it's what the doctor expected. Like from 11.8 to like 23.8.
Well, are you storing that sample capped or uncapped?
Capped.
Okay. Yeah, it should be good for 24 hours. I don't know what would shorten it to begin with. I'm going to have to ask some of our other technical people for input. And it's within that 24-hour time of draw time frame?
Yes.
Yeah. Check your QC, and I will have to check some of our other technical folks and see what they can come up with. Offhand, I'm drawing a blank.
Okay, thank you.
Sorry about that.
Thank you.
There are no questions at this time, but I would like to remind everyone, if you have a question, please press star 1.
Okay, I have some questions on the website. Kathy asks, a seasonal change in INR due to fibrinogen. I have never heard of fibrinogen be affected by the seasons. That's a good question. I'll have to look that one up too. Generally, the prothrombin time test is not really very sensitive to fibrinogen. You're going to have to get below 100 mg per DL before you start seeing increases in fibrinogen, in the PT time. So I would not expect that the INR would really be affected by the fibrinogen, by contribution to prolongation of the PT. Gail asks, what is the most common preanalytical factor that affects PT? I would say probably a short draw, which is going to prolong your PT if it's hemolyzed or partially activated. And sorry, Cynthia said she didn't get all the slides. We will, Cynthia, please email myself or Naomi, and we will email you that presentation. Okay, Tim asks, many physicians want an INR value even though the patient is not on Coumadin, pre-surgical or a day surge patient. It is, in your opinion, an appropriate use of INR, or would you recommend reporting prothrombin time in seconds, referring to our normal range in seconds for patients not on oral anticoagulant therapies? The INR system, as I mentioned, was developed solely for the use of monitoring oral anticoagulant therapy, because it is a calculation, and you're using that ISI, which has been established by testing samples from patients on stable oral anticoagulant therapy. So there has been some debate in the literature as to whether it is appropriate to use the INR for patients that are not on warfarin therapy, specifically if they have liver disease. In my opinion, I think it should just be used for warfarin therapy, but that opinion is not shared by many in this country. I know there are quite a few hospitals in the U.S. that don't even report out the PT anymore, so they're just reporting out the INR. And the reason why they did this, or the number one reason why they did this, is because of they didn't want to have to keep changing their therapeutic ranges every time they change reagents or reagent manufacturers. So my opinion, and it's just an opinion, would be to report both and reserve the INR for warfarin therapy, though I know physicians are so now attuned to INR that they're going to be looking at that value even though the patient's not on warfarin therapy. Another question, Terry Peterson asks, I think you're going to have to send me or call me because I'm not understanding it. Does Stago provide a low phosphate reagent so we can test for lupus anticoagulants? Oh, I know. On the PT assay, there is a test for the lupus anticoagulants called a dilute PT assay. It's one of the screening methods for detection of lupus anticoagulants, where you actually have to take your prothrombin time reagent and dilute it out, because as I've mentioned, high phospholipids will neutralize the effects of the anticoagulant. Unfortunately, Terry, the answer to the question is no. We do not have a specific PT reagent which is already diluted, so you would have to do the manual dilution. Barbara asks, do we have any information on the effect of the flu vaccine on warfarin? Good question. I will have to go back to the CHEST guidelines and look at that because I don't know the answer to the question. And Anne asked another question, which again, I'm sorry, Anne, I'm not understanding completely your question. I think she's saying that unopened, can you store for 24 hours? It's my understanding that the NCCLS guidelines state that you keep your PT sample, it's good for 24 hours if you keep it capped. Are there any other
we do have a signal
questions
coming in from Terry Peterson with Cal Sipple Regional Medical Center.
Okay. Hello?
Mr. Peterson, your line is open. Hearing no response, we'll move on to Lori Tonelli with Glen Falls Hospital.
Yes, it's Bill Loeb for Lori Tonelli, Glen Falls Hospital. Can you hear me?
Yep.
Great. We've been wondering if this worked. Two questions, actually. First was, you mentioned that the program was recorded.
Yes.
I think it's been a very thorough program. Are we able to get a copy of that recording?
Yes, we'll have an audio CD of the recording and also a CD-ROM which will have the slides. I know it didn't work the last time, that's why I did both. So just send an email request to Naomi and she can send out the CD. It'll probably take us a few weeks to get that though.
Okay, that sounds good. Second question was actually a follow-up on an earlier question regarding the effect of flu vaccine. We see on slide 37 under potentiation that
Oh, is it listed?
level of evidence number 2 has flu vaccine listed.
Oh, okay.
Could you tell us again what that slide was about, the potentiation, what that means?
Oh, that means that it will actually enhance the effect of warfarin. So let's see, where was it? Flu vaccine.
The last one under number 2, right after.
Oh, great. Good. Yeah, so, but that wasn't a level 1 study. So what that means is that in some study, maybe a smaller study, the flu vaccine, those patients were shown to have an enhanced reaction with their warfarin. I don't know the specifics of that study. I would have to look it up, but possibly maybe they had some bleeding problems or their INR was all of a sudden high. So that's what that would mean.
Okay, thank you very much.
You're welcome. There was one other question on the internet. How close of a correlation should you see with a laboratory instrument INR and a point-of-care PT? God, I knew somebody was going to ask me this question. This is really a Coag 110 question, not a Coag 101. The point-of-care PT analyzers have been a great from the patient's point of view because they don't have to go back to their physician's office or their anticoagulation clinic. They can theoretically do it at home, or they can go to a clinic and get it done without, while they're right there, and don't have to wait for the sample to be spun down and lab time and all that. The problem, or not the problem, but the challenge is that the correlation between the laboratory INR and the point-of-care device is not very good above the therapeutic range of about 3 to 3.5. It's my understanding, and I just was looking over some of the papers before we started today, that most of the point-of-care devices are going to be on the high side, so there's a positive bias. It doesn't mean these are devices that should not be used, but what it does mean is it makes it very difficult to keep switching between testing. So if a patient's stable on a point-of-care device, continue to keep testing them on that point-of-care device. The problem is going to be when they have to get admitted to a hospital and then they're being tested on a different laboratory instrument combination. We do have several Stago customers that have done these correlation studies. I know one customer out in Seattle is using the Rapid point of care, and then that device you actually are allowed to adjust the laboratory mean normal. So that's one way you can adjust your results to tweak the correlation. But generally, the higher the INR, the less, the correlation just isn't very good. Last question, when the doctor asks for a thrombin time, what exactly is he looking for? This is actually a different test. A thrombin time is another clotting time assay where you're just taking the patient sample and mixing it with a reagent which contains thrombin. And again, the clotting time is your result, so your result is in seconds. And this is done if somebody has if you're not sure if the patient's on heparin, they're going to have a really prolonged thrombin time. So some labs use this as a screening to figure out whether there's heparin on board. Also, if somebody has a problem with their fibrinogen, if they have a mutated fibrinogen, that is going to give them a prolonged time. So often a thrombin time test is included in a hypercoag panel. Are there any other phone questions?
There are no questions at this time.
Okay, great. If you do have questions in the future, please send me an email. My email address is Laura, Laura, .Worfolk, WORFOLK. It's just like Norfolk, Virginia, but with a W, at Stago, STAGO, -US.com. Thank you, and have a good day.
That concludes today's Coag 101 conference call. Thanks for attending, and have a great day.